Research has shown that a woman who has never had children, who waits until after the age of 30 to have children, runs a higher risk of developing breast cancer. What's not so well known is that these cancer treatments, whether it be chemotherapy, radiation, surgery, will potentially destroy a woman's fertility potential. When an oncologist offers the services of a reproductive endocrinologist, and that's an OBGYN who has had special training in the field of reproductive endocrinology, which is the study of a woman's fertility from the beginning of their life through the continuum. When they are offered these services, the patient then realizes that they do have the ability to possibly preserve their fertility. The oncologist doesn't need to be an expert in reproductive endocrinology. They just have to be able to offer the risks and benefits of the cancer treatment on their fertility ability. They need to make them understand that the treatment can destroy their ovaries, their eggs, and the ability to conceive children later on in life. The reproductive endocrinologist then will discuss all of the options available with the patient. The American Society of Clinical Oncologists back in 2006 deemed it necessary that the oncologist at least offer these services to the patient. What they found is that even if the patient didn't move forward with fertility preservation, that knowing that there's the option out there has increased their outcomes with regards to their cancer treatment. What we're finding is that 60% of oncologists still do not give this information out to patients, and that becomes very problematic. What the patients are finding is that they are not being told that these options are out there for them, and what happens, they go through the cancer treatment, and then they come and see the reproductive endocrinologist, and at that point, it's too late. So there's different protocols for women when they come through the reproductive endocrinologist's office or an REI center or better terms of fertility center. We either have the single woman or we have the married woman. And the first thing that we want to make them understand is that we can start this procedure within 24 to 48 hours of them coming to see the fertility specialist. And it usually just takes about 10 days to 2 weeks to complete a cycle. And then they can start to do their cancer treatment. So women can choose to cryopreserve or freeze oocytes or embryos, and oocytes are eggs. Usually we find that women who are single and they don't have a partner will choose to cryopreserve their oocytes so that down the road when they're ready to start a family and they do have a partner, then the oocytes can be inseminated with the sperm of her partner and it will create embryos and then we will transfer the embryos back into the woman. For women that are married, for them sometimes this can pose a problem. More than not, the embryos are created using the eggs and sperm of this married couple. But what we've seen is that sometimes the cancer treatment can take such a toll on the patient's life that by the time they're finished with the chemotherapy treatments, the marriage no longer exists. So now the woman has cryopreserved embryos with the spouse she is no longer with. So one of the problems that a woman can face is, do they want to cryopreserve oocytes or embryos? And if they say they want to do the oocytes, then the husband usually gets very upset about it. So what we like to do is completely lay out all the options for them so that they can make the right decision. Having an informed decision is the most important thing you can offer a cancer patient. So many of the women choose not to proceed with fertility preservation. And some of the reasons why is that it's very overwhelming. There's so much going on with their cancer diagnosis that they just don't know which direction to move in. and they find that they're getting information from family members, friends, from other clinical people. So because they're feeling so overwhelmed, they feel, well, let me deal with my cancer diagnosis right now instead of moving forward with the fertility preservation. The problem is that down the road, they will then regret it if they can't start a family. Financial issues play a very important part in this decision because for the most part, fertility preservation is not covered by insurance. And we find that very interesting because the insurance companies say that a woman is not infertile yet. She won't be infertile until after she receives the chemotherapy. So what happens is these women have to pay for everything out of pocket, and it can be quite expensive. A normal egg freezing or embryo freezing cycle can cost about $8,000, and on top of all the other medical bills that these patients are in the process of having to pay for, the $8,000 just puts them over the top. One of the things that is offered through many of the fertility centers is an affiliation through an organization called Fertile Hope. And this organization works with the fertility centers to arrange for discounted cycles, free medications, and a variety of other things to help the patients offset the financial cost. So if we can offer that to the patient, then a lot of times they will make their decision if the financial issues are being handled. Sometimes one of the reasons why patients do not choose to move forward with fertility preservation is that they can't concentrate on more than one problem at a time. And as I stated before, the patients feel so overwhelmed and they feel that the cancer diagnosis is the most important, so they deal with the cancer diagnosis first. Timing is also another indicator of whether or not that they will proceed. The patient speaks with their oncologist, and the oncologist will tell them, we need to do surgery tomorrow, or we need for you to start your chemotherapy in a week. And if that's the case, then a lot of times the patients won't even come and speak to the reproductive endocrinologist. What we have found, however, is that if the reproductive endocrinologist and the medical oncologist consult with each other, that for the most part they can come to a compromise, and if we can start that person's cycle right away, more than not, we can have her start a cycle, retrieve her eggs, and then she can move on with her cancer treatment. Can the patient wait that long? Well, that's a good question because in the patient's mind, they need to start their treatment yesterday. And it's important for the reproductive endocrinologist and for the oncologist to relay to the patient is that, yes, they do have this time frame. Now, of course, there are some cancers that are so far along before they're diagnosed that the patient does need to start her treatment right away. But everything that I've seen in my experience is that the patient can usually wait 10 days to 2 weeks before they start their chemotherapy. Once the woman chooses to move forward with fertility preservation, a few things come into play. So the patient will have to talk to her oncologist and find out, will I ever be able to use these embryos down the road? Am I going to be able to carry them myself? What's my diagnosis? What are my long-term prognosis? And what we found is that with all the recent discoveries and treatments for breast cancer especially, that women are going into remission and they are being able to use their embryos so that they can start their family. Although some of these women, they do wind up having surgery where their uterus has to be removed, so what they're going to need to do in the future is get what we call a gestational carrier. And that person will carry the embryos for the patient. So as you can see, there's quite a few options for patients who choose to go through fertility preservation with a cancer diagnosis. They need to discuss with their families the financial obligations, the long-term ramifications, and overall what is best for the patient so they have the best possible outcome um, down the road.